So, what happens when a life-saving medical procedure is legally put on the same level as a violent crime? It sounds unbelievable, right? Well, today we're going to dive deep into a shocking court case from South Korea where that is exactly what happened. We are going to dissect the verdict that held a doctor jointly liable with a criminal assailant for a patient's death. And then we're going to use that case as a launchpad for a comprehensive review of the risks we all manage every single day, central line complications. This is a crucial story about where clinical reality collides with legal consequences. Let's get in. But before we get into the heavy details of this case, I just wanted to start by saying, hello anesthesiologists. Commuting to and from work in this cold weather must be very challenging. Please take care and avoid catching a cold. Bonjour chers médecins anesthésistes. Les trajets quotidiens par ce temps froid doivent être éprouvants. It's really in that spirit of collegial support that we're going to tackle these tough topics together. So thank you so much for joining me. All right, here's our game plan for today. First, we are going to walk through the timeline of that truly shocking verdict in Gwangju. Then we'll try to get our heads around the court's decision. After that, we're going to pivot to a full clinical review of CVC complications, both the immediate ones and the delayed ones. We'll look at another really insightful clinical case, and then we'll wrap everything up by talking about how to navigate these new medical legal risks. Okay, let's start with Section 1, and the case that prompted this entire discussion. Our story begins not in an operating room, but with a horrifying act of dating violence. And it ends with a court verdict that sent an absolute chill through the entire South Korean medical community.
Let's walk through this timeline, because every single minute here counts. It all starts in the very early hours of October 6, 2017. At just before 4 a.m., a young woman is assaulted by her partner. She's pushed, she falls, she hits her head, and the result is a devastating epidural hematoma. By 8 a.m., she's at the hospital, but a repeat CT scan shows every surgeon's fear. The bleed is getting bigger. Emergency surgery is the only option. At 10:20, she's wheeled into the OR. A first-year anesthesiology resident begins the prep, which includes placing a central line. And then, at around 11 o'clock, everything goes sideways. During the central line attempt, the patient's vitals just crash. Her blood pressure tanks, and her heart rate skyrockets. This is the moment the case pivots from one tragedy to another. A mere 29 minutes later, a chest x-ray confirms a new catastrophic problem, a massive hemothorax. The team scrambles. They get a chest tube in. They do an open thoracotomy. They're pouring in blood, but it's just too much. By 12:50 p.m., she's gone, dead from hypovolemic shock.
And this is the legal bombshell that just stunned everyone. The court didn't just find the medical team negligent. No, it went a step further and legally chained their actions directly to the initial criminal assault. They used this specific legal phrase, objective related commonality, which basically says that these two totally separate events, the violent push by the boyfriend and the alleged medical error in the OR, were so connected in producing the final outcome that they were, in the eyes of the law, a single act. Just let that sink in for a moment. An attempt to save a life was legally put on the same plane as the violent crime that endangered it in the first place.
And this wasn't just some abstract legal principle. It had very real consequences. The court ordered the assailant, that first-year resident, and the hospital to jointly pay the victim's family 444 million Korean won. That's well over 300,000 US dollars. The word there is jointly. The financial blame, the professional blame, it was identical for the doctor and the criminal who set this entire tragedy in motion.
So you have to be asking, how on earth did the court get there? Well, in this next section, we're going to deconstruct that legal reasoning. We'll look at the specific duties the court said were violated. So this term, objective-related commonality, is the legal key that unlocks the whole verdict. The easiest way to think about it is with a totally different scenario, like a car crash. Okay, imagine driver A illegally parks their car, no lights on, dark color, right on a dangerous curve at night. A little while later, driver B comes tearing around that same curve, speeding, and slams right into the parked car. So, who's at fault? Well, this legal doctrine says they both are. Their separate wrongful acts, the illegal parking and the speeding, combine to create one single indivisible tragedy. The court took that exact logic and just dropped it right onto this medical case. They said the assault created the life-threatening emergency, and the doctor's alleged error during that emergency directly led to the death. In the court's view, you just couldn't pull the two apart. The court's finding of negligence really came down to a breach of two fundamental duties that we all know well. First, there's the duty of care. This is our technical skill, right? The basic expectation that we perform our procedures with a standard level of competence. And second, there's the duty of explanation, which is all about informed consent, making sure the patient, or in this case their guardian, really understands the risks before they agree to anything. The court said the medical team failed on both counts. And the court was incredibly specific about why. When it came to the duty of care, the autopsy findings were absolutely crucial. They found a 1 to 2 millimeter perforation in the right subclavian artery. And the court's logic was pretty straightforward. The resident was aiming for the internal jugular vein. Puncturing the subclavian artery, a vessel way below the target, wasn't just a known complication in their view, it was a fundamental technical mistake that directly caused the fatal hemorrhage. Then, for the duty of explanation, they put the consent form under a microscope. And what they found was a generic anesthesia consent form. It didn't specifically list the big, scary risks of a central line insertion itself, things like arterial puncture, massive bleeding, or even death. And because of that, the court ruled the family's right to self-determination was violated. They never gave truly informed consent.
Okay, so a case like this forces us. It demands that we step back and re-examine the risks we handle every single day. So let's move away from the courtroom and get back into the clinic. In this section, we're going to do a really detailed review of those immediate mechanical complications that can happen with a CVC placement.
The very first thing we have to talk about hits incredibly close to home, given the Gwangju case involved a first-year resident. This data just lays it out in black and white. Look at that difference. A study found that inexperienced operators, so we're talking interns, junior residents, at a complication rate of 11%. That is nearly double the 5.4% rate for experienced attendings and senior residents. It's a stark reminder of the steep learning curve and just how critical supervision, good training, and knowing when to call for help really are.
Let's start with the heart. The most common thing we see, by far, are arrhythmias. Now, this is usually totally benign, right? It's just the tip of the guide wire tickling the inside of the right atrium, causing some ectopy. That's why we're glued to the ECG during insertion. You see a run of PVCs? What do? You just pull the wire back a couple centimeters. Simple. But what's not simple is cardiac perforation and tamponade. This is the nightmare scenario. This happens if the guide wire or the catheter gets advanced too far, too forcefully, and actually punches through the wall of the atrium or ventricle. This reinforces two golden rules. 1. Always confirm your final tip position with imaging, and 2. Never force a wire or catheter that's meeting resistance. If your patient suddenly crashes right after you place a line and they're not responding to fluid, you have to have cardiac tamponade at the top of your differential.
Now, vascular complications are without a doubt the most common mechanical problems we face. And arterial puncture, the central event in our Gwangju case, is #1 with a bullet. The incidence is probably higher than most of us realize, somewhere between 4 and 9%. And this is where ultrasound has been an absolute game changer. But what do you do if it happens anyway? What if you realize you've threaded your dilator or the catheter right into the carotid or subclavian artery? There is one thing you must remember. Do not pull it out. I know it's counterintuitive, your first instinct is to pull it out, but that can create an uncontrollable high-pressure bleed. The standard of care is to leave it right where it is, secure it, and call for an immediate vascular surgery consult. Let them fix it in a controlled environment.
All right, let's talk about the lungs. Pneumothorax is the classic complication we all learn about, especially with the old-school landmark subclavian approach. A hemothorax, like we saw in the Gwangju case, is less common but way deadlier. And again, ultrasound is your best friend here. It lets you actually see the pleural line and stay away from it. Now, the rarest, but maybe the most terrifying complication is a massive air embolism. This can happen if a hub is left open to air, especially if the patient takes a deep breath. Your management has to be immediate. You have to trap that air. You put the patient head down in Trendelenburg and then roll them onto their left side. This is called the Durance maneuver. The idea is to trap that air bubble in the apex of the right ventricle, keeping it away from the pulmonary outflow tract while you flood them with 100% oxygen and try to aspirate the air back out of the catheter.
So those are the things that can go wrong right away. But what about the problems that sneak up on us? Let's move on to the delayed complications, the ones that show up days or even weeks down the line. We're mainly talking about infection and thrombosis here.
Let's talk about the silent killer, CLABSI, central line associated bloodstream infections. Now, have a look at this chart showing the usual suspects. This is really interesting. We tend to focus on skin flora like Staph aureus and coag-negative staph, but look at the data. Gram-negative bacteria and fungi like Candida actually make up the majority of these infections. So what does that mean for us in the clinic? It means when a patient with a central line gets a fever, our first-line antibiotic coverage has to be broad enough to hit these guys, not just the usual skin bugs. Preventing CLABSI is all about knowing the risk factors. I like to think of them in 3 big buckets. First, there are patient-related factors, things we can't really change, like if they're immunocompromised. Second, catheter-related factors. These are our choices, how long the line stays in, how many lumens it has, and where we put it. The femoral site is usually the highest risk. And finally, there's operator and care-related factors. This is where we have the most control. This is where insertion bundles,
sterile technique, hand hygiene, and meticulous line care become absolutely non-negotiable. Beyond infection, the line itself can just wear out or cause problems over time. A really common one is a fibrin sheath. You know this one. You can flush fluid in, no problem, but you can't draw blood back. Then there's something more dramatic, catheter fracture. This happens most often with subclavian lines because of something called pinch-off syndrome, where the catheter gets repeatedly squeezed between the clavicle and the first rib until it just snaps. And then you have a piece of plastic embolizing to the heart or lungs. And finally, let's not forget that a central line is basically a big foreign object sitting in a major vein. It's a huge risk factor for developing a DVT, which can, of course, lead to a pulmonary embolism.
You know, looking at tables and charts is one thing, but real clinical cases are where these lessons really hit home. So in this next section, we're going to look at another case to see how these complications actually play out.
Okay, check out this scenario. We have a 30-year-old woman on hemodialysis. She's had a right subclavian CVC for about 2 weeks. The line starts acting up, so it gets removed. But then, just 20 minutes later, she suddenly can't breathe, she has chest pain, and her blood pressure completely bottoms out. The critical twist here is that the disaster happened after the line came out, not when it went in.
The X-rays tell the whole story. On the left, that's the film from the initial placement. See how low that catheter tip is? Now look at the image on the right. This was taken after she collapsed. The difference is just, wow, it's a massive right-sided hemothorax that has completely opacified her right lung field. And here, we see the life-saving intervention. They got a chest tube in, and it immediately drained 700 cc's of frank blood. This follow-up X-ray shows a huge improvement. The blood is draining, and the lung is starting to re-expand. Because of this quick thinking and some blood transfusions, the patient actually survived.
So what's the big takeaway from a case like this? It really boils down to 4 non-negotiable principles. First, positioning is everything. The tip of that CVC needs to be in the lower SVC or at the cavo-atrial junction, period, and you have to verify it. Second, it's another vote for ultrasound guidance to reduce that initial risk of vessel injury. Third, taking a line out is not a benign procedure. We need to have monitoring protocols in place, especially for that first hour after removal. And finally, you have to maintain a high index of suspicion. What most likely happened here is that the vessel was perforated during the initial low insertion, but the catheter itself was acting like a plug, tamponading the hole. As soon as it was pulled out, the hole was unplugged and the massive hemorrhage began.
All right, let's bring this all home. In our final section, we're going to merge the harsh legal lessons from that Gwangju case with our clinical review and try to build a practical framework for a safer practice in today's world.
So how do we protect our patients and, frankly, protect ourselves? Here are 5 key strategies. Number 1, embrace ultrasound. Real-time ultrasound guidance isn't a luxury anymore, it is the standard of care. Number 2, our consent process has to be better. Directly responding to the Gwangju verdict, our forms need to explicitly name the big bad complications: arterial puncture, hemothorax, pneumothorax, death. Number 3, know your limits and check your ego at the door. There is zero shame in asking a more senior colleague for help with a difficult line. In fact, it's the mark of a true professional. Number 4, always, always, always confirm your line placement with imaging before you use it. And number 5, use checklists and structured protocols for insertion, for maintenance, and for removal. They exist to make sure critical safety steps are never, ever missed.
And that brings us to the final, and maybe the most difficult question of all. The Gwangju verdict really shines a spotlight on this incredible tension in medicine today. Our training, our entire professional ethos pushes us to act fast, to be decisive in emergencies, to save a life. But at the same time, we're facing a legal landscape that seems to be increasingly unforgiving of any outcome that isn't perfect, sometimes failing to see the difference between a calculated risk taken in a desperate situation and true negligence. Figuring out how to balance that duty to act decisively against the very real threat of litigation, that might be the single greatest challenge facing our profession right now. It's a question with no easy answers, and one we all need to be thinking about. Thank you for joining me today.